Hello everyone, welcome back to MedReader. This is Dr. Bhavsar. On today's topic, I want to discuss about acute pancreatitis. We're going to go over like an overview of this topic, starting with epidemiology, pathophysiology, and some of the things which are kind of like paradigm shifting that we're going to discuss on this topic. So stay tuned and watch it till the end. So let's start with this. Right now, over 300,000 of annual US admissions are being done for acute pancreatitis, and it's definitely it start off as a simple diagnosis involving simple treatment, but sometimes it can turn into a high mortality condition, which is going to be the complications of the initial pancreatitis. So you have interstitial edematous pancreatitis up to 80 to 90% of all the pancreatitis cases present this way. It's characterized by inflammation and edema surrounding the pancreas, and also organ failure and third spacing if it progresses. It is generally self-limiting. Just pain management and IV fluids is enough for that. But it can also progress to a more worse condition, which is called necrotizing pancreatitis. Now, this can be, very frequently also associated with infected or infectious necrotizing pancreatitis. So, this is going to involve the use of IV antibiotics. But you do see necrosis of the pancreatic parenchyma in this condition, and there is peripancreatic fat degradation too. This can be appreciable on imaging. So CT abdomen for a worsening acute pancreatitis patient is often used for diagnosing the situation, and mortality can reach up to 15 to up to 40% if you're dealing with an infected acute pancreatitis. So the big three etiologies you need to remember is gallstone pancreatitis. Up to 40 to 70% of all cases of acute pancreatitis present this way. It's the most common cause. You're going to see elevated liver enzymes, and you're going to see cholestatic pattern of hepatitis, meaning that you'll see elevated LFTs, but you're going to also see elevated alphas with that ALP. Alcohol, 25 to 35% of the causes are alcoholic pancreatitis, but you need to remember that you need a pretty significant amount of heavy alcohol use in order to cause acute pancreatitis, which has been discovered with studies over years. Currently, as I have researched about this topic, more than 50 grams per day for more than 5 years is the amount of alcohol you need to consume. And binge drinking episodes here and there sometimes, that might be present in the history, but remember, that's not associated with acute pancreatitis. You need a prolonged heavy use or a user of alcohol. Most of the cases are also acute flares of someone who has had chronic pancreatitis, again, in history, chronic user, now having an acute flare of pancreatitis. Yes, think about alcoholic pancreatitis in that case. The third cause is hypertriglyceridemia. This is one of the miscellaneous causes. When you can't find any gallstone or you don't find alcohol use, you search for this. Although today, it is a part of the pancreatitis workup, so we do it. Up to 7% of hypertriglyceridemia patients going to present with acute pancreatitis. The risk is the highest when the triglycerides are more than 1,000 milligram per deciliter. At that point, when you draw the blood, even that blood is going to look kind of milky. Excessive triglycerides hydrolyzed into cytotoxic free fatty acids, and that is the reason they're going to cause the acute pancreatitis. So the management of these three are going to be very different. Let's go to the next slide. The domino effect. This is kind of like explaining the pathophysiology in sequences of what exactly happens. So you have step 1, premature activation. The damage to the acinar cells has triggered inappropriate intracellular activation of trypsinogen to trypsin. So that's going to start degrading the pancreatic tissue. That's where the autodigestion begins, the step 2. Trypsin activates elastase and phospholipase A2. It causes the autodigestion of the pancreatic parenchyma. It's like suicide of the pancreas, but which is induced by pathologies which you might know, the mnemonic smashed and other causes. So from that autodigestion step, the step 3 is the inflammatory response. That's how the damage to the pancreatic tissue is gonna convert into a massive release of pro-inflammatory cytokines, including TNF alpha, IL-6, IL-1, and that's gonna constitute your SIRS response, which then the patients are gonna present with all those worsening scores of BISAP and everything clinically. Systemic collapse. So when this inflammatory response is extremely severe, you're going to start having capillary leak, third spacing, hypoperfusion, ischemia, and organ damage. And these are the patients who are going to be more sicker, requiring more intensive care in the ICU. So you need to remember the revised Atlanta criteria, the RAC, to lock in the diagnosis. This is characteristic abdominal pain, usually epigastric, often radiating to the back. The elevation of lipase, more specifically, and or amylase, 3 times more than the upper limit of normal. Now, if you have these two conditions, the characteristic abdominal pain and the lipase more than 3 times the upper limit of normal, that's pretty much diagnostic of acute pancreatitis. In most of the cases, you won't even need imaging, but you can go ahead and do a CT scan of the abdomen, MRI, or ultrasound if imaging is indicated. But remember, CT is not required in order to diagnose acute pancreatitis. 80% of your patients are going to be diagnosed with clinical and enzymes alone. So just to keep in mind for board questions. So triage and severity. There are certain bedside blood markers or clinical markers that you can use in order to see how severe the pancreatitis is progressing into. Your hematocrit is basically telling you how concentrated the blood is. Or in other way, in acute pancreatitis, what level of interstitial flooding is happening. So let's say you have a patient who is hypotensive and their hematocrit is rising. This is going to suggest that they're hypovolemic. All that fluid is third spacing somewhere. And the IV fluid at what rate you're giving might not be sufficient enough. Your BUN trending up is strongly correlating with mortality, and it's a part of the BISAP score. SIRS criteria, if they're still present at more than 48 hours, that's also not a good sign. Remember, you need at least 2 or more SIRS criteria here. CRP more than 150 has a positive predictive value for a severe disease. So all of these are constituents of the BISAP score that is frequently used. So remember, mild, no organ failure or only local complications. You can discharge patients within a week. Moderately severe, you have transient organ dysfunction. It can be elevated kidney biomarkers. It can be worsening liver function. It can be a worsening serositis or third spacing. Transient organ failure within 2 days is still considered moderately severe. Now, severe is where you have a persistent organ failure beyond 2 days. This carries a high mortality, and these patients need special attention. The first 72-hour aggressive hydration rule is kind of like, under reconsideration since the advent of the WATERFALL trial that was done in 2022. The findings of this trial, now this is important to understand. The findings of this trial suggested that aggressive fluid resuscitation that has caused 3 times more fluid overload when studied in this particular stage they saw 20% versus 6.3% of fluid retention rate in patients that were treated with aggressive fluid in acute pancreatitis. So now they have come up with different, infusion rate, where the LR infused at 1.5 to 3 milliliter per kg per hour is more goal directed and has achieved better resuscitation results. The old aggressive IV fluid regimen was 5 to 10 milliliter per kg per hour. Now, that's a little too much, especially if you're considering someone with a weak heart, someone with a weak kidney. They're going to have a lot of fluid retention. So even if they don't have those conditions these days, they have proven with this trial that 1.5 to 3 cc per kg per hour is more than enough. Now, if you see that your patients are undergoing effects like hypovolemia or persistent end organ dysfunction or persistent lipase elevation that is not improving, pain is not improving, you can potentially go up on the fluid rate, but you start with this and see how it works. So that's kind of like practice changing. Also, along with conservative fluid management, the nutritional guidelines these days, they also say that now it is recommended that acute pancreatitis patient gets early enteral feeding. So if you have a mild acute pancreatitis case, you can start oral feeding with a low fat diet within 24 hours, basically. And if your patients are sicker, then they can get an enteral tube like NG or NJ tube. And still, it is recommended to start feeding within 72 hours in that case. So overall, early feeding is now encouraged more, along with conservative IV fluid management, to better fine-tune the practice of treating acute pancreatitis. And remember, avoid TPN. There's no indication for that. The whole point of early feeding is to preserve the gut mucosa, which prevents the bacterial translocation. TPN does not fulfill that goal. Antibiotics, remember, they are not indicated for mild to moderate pancreatitis without any evidence or other evidence of a systemic infection like fever or leukocytosis or something like that. They're only targeted when you see signs of the suspected infection, or if your patient is having the acute cholangitis signs, in which they can have right upper quadrant pain, they can have fever, worsening jaundice in that situation. So for milder cases, just pain management, conservative IV fluid, 1.5 to 3 cc per kg per hour, and early feeding is what you need to remember. Okay, so the ERCP timing, this is from the APEC trial in 2022, this info. Routine urgent ERCP does not reduce complications. So remember that. You have an acute pancreatitis case, it's mild to moderate. You can potentially think about ERCP if things are worsening, but performing an urgent ERCP within 24 hours would only be necessary if you're dealing with concurrent cholangitis, not improving to antibiotics, progressive biliary obstruction, worsening jaundice. So if you don't have those complications, ERCP, you don't need to go anywhere near that. The cholecystectomy mandate is going to be tested on boards too. There's questions on this. So same admission cholecystectomy is now the standard of care within 24 to 48 hours of the mild cases. And you only delay this doing a cholecystectomy only for severe cases where peripancreatic collections resolve. So yeah, do not let a patient with mild biliary pancreatitis leave the hospital with a gallbladder is what I would say. For the hypertriglyceridemia induced acute pancreatitis, you initiate therapy you have to do something for this. So you initiate therapy when triglycerides are more than 1,000 as a rule of thumb. I have seen some physicians, even at the level of 800s and 900s, they start this. It all depends on, how clinically the patient is appearing. So you can do that. But more than 1,000 is the initial threshold. The primary therapeutic goal in this case is to reduce down the triglyceride levels below 500. So what are some immediate things that you can do? You can do insulin infusion, you can do therapeutic plasma exchange, and you can do heparin. Now, insulin infusion, this is going to be a very slow infusion, 0.1 to 0.3 unit per kg per hour. It enhances the lipoprotein lipase, which clears the chylomicrons. The pros is highly accessible. You can do it by transferring the patient briefly to the ICU, cost effective. Then the other forms, obviously, and it's going to require a constant glucose monitoring due to the risk of hypoglycemia and sometimes co-administration of D5. Therapeutic plasma exchange directly is going to remove and filter the triglyceride rich lipoproteins. So it's actively clearing the LPLs. In the previous one, you activate the body's lipoprotein lipase to clear up the microns. And this one, you just remove them with therapeutic plasma exchange. Now, this is more procedural. This is more, I would say, resource heavy. The pros is although you achieve rapid 70% reduction in 24 hours, and it's ideal for severe cases in pregnancy, but cons is high cost. It's going to require a central line, and you need a nephrologist to undergo this procedure. Heparin, it releases endothelial-bound lipoprotein lipase into the circulation. So insulin enhances the LPL activity, and this heparin it releases endothelial-bound LPL into the circulation. So it's kind of like an indirect way. It's readily available. The pros are it's readily available in all ward settings, but the cons are the effect is very transient, and it may paradoxically deplete the LPL stores over time, and plus the increased risk of bleeding because you're basically adding heparin. So I haven't seen in my practice heparin being used for this condition. It's always going to be start with insulin infusion. Most of the cases, like 90%, I've seen they resolve with insulin. In some cases, you might need TPE, but that's going to be case by case. So this slide, a little bit busy, but it's based on classifying the local complications. So you have time of maturation against the morphology and the types of fluid, like homogeneous fluid only types and fluid plus solid necrotic debris type. So you have APFC within 4 weeks, ANC also within 4 weeks. Pancreatic pseudocyst, it's far apart, more than 4 weeks, and something called WON, walled-off necrosis, is also a later presentation. So the earlier ones, the acute pancreatic fluid collection and no defined wall usually is going to resolve spontaneously. So you just see some fluid collection around the pancreas. You don't see any definitive walling or abscess kind of thing. It usually goes away on its own. Now, acute necrotic collection, if it's identified on imaging with variable fluid, it's going to show the variable fluid and solid, but you're going to see solid necrotic debris in there, but you don't see a defined wall around it. So you see necrosis, no defined wall, that's ANC. But the difference between the APFC and ANC is going to be APFC is homogeneous fluid only, but the necrotic is you have solid components of necrosis on imaging. Now, the later presentations, more than 4 weeks complication, is pseudocyst formation, well-defined mature wall containing purely fluid and zero solid debris. You can watch this, or if it's problematic, they can be drained. The walled-off necrosis is an encapsulated mature wall which is containing solid necrotic debris in that. A little bit more serious intervention gonna be needed for this one. So what is the step-up approach to the infected necrosis? Crucial timing rule you need to remember is um, delay intervention. Wait up to 4 weeks for the collection to mature into the wall of necrosis to demarcate the viable tissue and make the debridement safer. So how do you approach this? You have a patient with acute pancreatitis. Now they have acute infected necrosis. You start off with the targeted antibiotics. Now, step 2 is going to be you do have options with either percutaneous or transluminal catheter drainage of that necrotic tissue. This may be used for more definitive culture of what's growing there in that drainage and to target the antibiotics. And up to 35% in the literature, up to 35% of the step-up patients never need to progress beyond this point. You have your diagnosis, you have your bug, and you treat it with draining and IV antibiotics. Some cases you need the step 3, which is going to be direct endoscopic necrosectomy, or you can also do minimally invasive surgical debridement, and then the full-blown surgical cases where the other 3 and 4 are not feasible is an open necrosectomy as an absolute last resort. But remember that critical timing rule, delay intervention, wait 4 weeks for the collection to wall off to demarcate the viable tissue and make the debridement safer if you're gonna go for the surgical option. Special populations and edge cases. Post-ERCP pancreatitis is seen, it's 5 to 10%. The prevention is very critical. Interestingly, you can prevent this by rectal indomethacin up to 100 milligrams, and you can also utilize prophylactic pancreatic duct stenting sometimes in high-risk patients. So they just put a pancreatic duct, which is gonna prevent the backlog, and that's how you're not going to get the post-ERCP pancreatitis. Keeping the patients well hydrated is also going to be something you can do. Pancreatitis in pregnancy, gallstones are the most common cause if you're dealing with a pregnant patient. Ultrasound is preferred imaging modality. MRCP without gadolinium is considered safe. Cholecystectomy is safest when performed in the second trimester. Autoimmune pancreatitis type 1, this is IgG4 related, suspected when imaging is showing diffuse enlargement. You're going to see sausage-shaped pancreas in this type, autoimmune pancreatitis. So you're going to see that the duct of the pancreas in the imaging are very narrow, almost non-existent, and your pancreas looks sausage-shaped. Classic sign in terms of imaging, also tested on the boards. The treatment is going to require corticosteroids, which typically, yields a dramatic and rapid clinical response. That's how you know this was the diagnosis. So something to remember. What are the down-term effects of patients who you just treated with acute pancreatitis or have repeated, episodes of acute pancreatitis? So they can develop exocrine and endocrine insufficiency. So exocrine insufficiency, it affects almost 27% of the patients at 3 years. Now, these are either patients with severe episode of acute pancreatitis or recurrent acute pancreatitis. Over 3 years, 27% can have exocrine deficiency. This is mainly fat-soluble vitamin loss and, in general, inability to reabsorb fat. So you're going to have steatorrhea, fatty stools, and fat-soluble vitamin deficiency. They can also lead to osteoporosis in future. So fecal elastase 1 less than 200 diagnostic for that, and you will need to provide them with pancreatic replacement therapy. So you need pancreatic enzymes for them. You also have post-pancreatitis diabetes. It's a type 3C diabetes. 23% of the patients are going to develop this condition. You avoid incretin based therapies like GLP-1 and DPP-4s, because remember they're also considerable risk of acute pancreatitis, so don't use that. Early insulin initiation may be required in these cases because the pancreas might be atrophic, and that's how they're developing this diabetes. Um, Acute pancreatitis is a lifelong metabolic shift. Evidence-based management of the acute pancreatitis and regular follow-ups is going to prevent long-term complications. So here's what residents, medical students, or even hospitalists practicing should know as a checklist when they're dealing with acute pancreatitis. Did you identify the etiology? Is it biliary? Is it alcoholic? Is it triglycerides? Did you draw IgG4? All of that. And did you deal with the biliary issues, the same admission, cholecystectomy if it was gallstone, or did you address the other biliary issues? Were the lipids corrected if it was hypertriglyceridemia? Did you confirm that the triglycerides dropped to less than 500 if that was the case? And did you prescribe fibrates on discharge? All those things. Can they tolerate nutrition? If they can, early feeding is, recommended these days. And fluid, also remember, you don't need to go that aggressive, 5 to 10. 1.5 to 3 cc per kg per hour of LR is gonna be, you can start off with that and see how the patient progresses. Long-term monitoring as an outpatient, follow up of their A1C, see if they're developing diabetes or not, and other stuff. So all right, I hope this video helped you guys, and keep watching MedReader for such educational videos, and we'll see you in the next one.